So that's a case with a mitral valve in ring implantation. It's about an 82-year-old female who was previously operated on the mitral valve with mitral valve repair, and she had received Edwards physio ring 30 millimeter. She has COPD, diabetes, a moderate renal failure, and Euroscore of 13. That's the valve with the ring, as you can see. That's the echo before. And the gradient was 7. I think that's Vlas's after she was intubated, because I think initially was even more than 7. And that's the ring, non-fracturable ring. And we made the CT first, and the neo LVOT was 181. It's borderline. But we had also some septal bulging, and therefore we decided to proceed to a tip-to-base lampoon. And Theo, Dr. Professor Kilis, was our secret weapon. And first we implanted a sentinel protection system, and then proceeded to a transeptal puncture inferior and posterior. And then we had an Mezilis catheter and an Inovi wire through the valve. And we made a balloon test, an inflation with a 26 millimeter balloon. We see that slow flow in the aorta. And after that, we created a VA loop with a long terumo, wife, and created and a rendezvous with a retro guide and the Agilis. And through that, we put a flying V, a wire which was bended, and with diathermy, we splitted the anterior mitral valve in the A2, and you see here, I think, the acute MR on the right panel that we created. And after that, we performed a balloon septostomy with a 12 millimeter balloon, and then a MyVal 29 was implanted with very good result. No paravalvular leak, no regurgitation, as you see also the fluoroscopy. No LVOT obstruction, of course, and no gradients between LV and LA. That's some images, an ASD, iatrogenic ASD from left to right with left to right shunt. In conclusion, valve in ring TMVR can be challenging due to the potential of inadequate anchoring, anterior leaflet displacement, and LVOT obstruction. Leaflet modification techniques may be necessary. Tip-to-base lampoon is a relatively complex procedure, but is effective in splitting the anterior leaflet if done properly, and the cerebral protection is mandatory. Thank you.
So that's a case that we very quickly presented before, but we thought that might be an opportunity to discuss the tips and tricks of doing this case. First of all, the selection. If you see the CT scan, the neo-LVOT was 180 millimeters square, and it's not too bad, it's not terrible. I mean, 180 is probably manageable. So we did discuss a lot before the case and during the case, the three of us, whether actually modifying the leaflet was necessary. That's why we inflated this 26 balloon, in order to have an idea what will happen with the neo-LVOT. To be honest, I'm not sure if that helped with the decision, because the balloon prolapses inside the LV anyway and blocks the flow, so it will look bulky. So maybe it's a step that for the next case we could not do. But the anterior leaflet had a couple of features that made this unattractive. So, for example, it was very thick. And thick means that it will not extend as much to the LVOT, so perhaps it's not necessary. And it was relatively short. Having said that, we measured it many, many times, and we had measurement between 18 and 25 millimeters. And looking in the literature, any anterior leaflet length of above 23 millimeters, in theory, could cause LVOT obstruction. So, unfortunately, when it comes to native leaflets, the CT scan cannot give you an accurate prediction of the neo-LVOT because it can only show you how far the valve protrudes into the LVOT. It doesn't take into account the length of the anterior leaflet, and that's the key. If your length is long, like this morning, Kostas Pargia showed this tear case in the repaired valve. If you had tried to put a valve-in ring, in this case, that the anterior leaflet was 30 millimeter, that would definitely cause obstruction. Doesn't matter what angulation you have, widening of the LVOT. The question is, now that we saw the Batman approach, which I think it's simpler, personally, would we do a Batman on this case, like perforate the leaflet and inflate the valve in there? I mean, that's an alternative as well.
Vlask, if I may interrupt you a little bit. So we just saw in Intrepid satellite symposium. So Medtronic people have this AI-generated algorithm that actually, can see if there is an increased danger of LVOT obstruction. So based on the CT mainly. So maybe it takes into account, I suppose, the measurements. But if you can get, maybe it's easier and it's more, let's say, liberalized this approach. This AI generation.
I'm not familiar with that. That might be as an option.
That would be an interesting,
The other thing that we need to measure in these cases, and this is happening already, is just if we use MyVal, we need to. I've already spoken to the company to do that. Is to measure the valve neo-LVOT and the skirt neo-LVOT, because if you have a septal bulge, if your anterior septum at the base is very, very thick, then you may modify the leaflet, but your septum is going to close the way anyway. And then you may do septal modification techniques, such as alcohol ablation or sesame or all this stuff. But if, on the other hand, the septum is thin and your leaflet is long, then it's nice to have a prediction of what will happen, for example, if your valve in the skirt area, because then the distal part in the LV, you don't care, because the cells are widely open. So if your valve in the skirt area leaves you a widely open neo-LVOT up to the IVS. So I think this is also very useful.
So in this case, if you have been doing that, tomorrow, would you do it the same, time or in the same way? Would you prefer to do a Batman procedure?
I mean, I've only done one Batman case and two of those, but so I'm not mega experienced. But I think Batman was easier to do, to be honest with you, because all you have to do is just find the leaflet in the end to perforate it, balloon it, and then put the valve in there.
Yeah.
So maybe, but having said that, I don't know, because the leaflet was thick. It was quite cumbersome. I mean, it didn't show how complex it was. I mean, we spent 2 hours to do this lampoon.
It's not easy, and you have to have an expert, to do that.
There was an interesting session in the New York Valves about electrosurgery, and Zafar Khan, who is the guru of this, described all the steps. It takes 3 people to do it. We did it 2 people, and we were holding and pulling and pushing each other. Eventually, we did it, but it wasn't very easy, because you have to hold your catheters, the proximal and the distal catheter, very stable, and then pull the wire. Make sure you don't lose the flying V position, because this area is denuded. So you scrape the insulation, you create a sharp V, and then you insert it into the patient.
So
then you have to create
NIH group, also showed some results before doing the lampoon. Letterman and Zafar Khan showed that maybe in some situations it's better to do septal ablation before. Right, so it's maybe in this case it's not the
provided you have enough septal thickness.
Doesn't look very hypertrophied, but yeah.
Actually, we published a comment about alcohol septal ablation when a letter to the editor come to our first publication with lampoon technique, and when we look at the alcohol septal ablation trials and cases, very harmful for these mitral cases, because these patients are sick and there is risk of arrhythmia development. And so instead of alcohol septal ablation, really lampoon and Batman techniques are much important. To be honest, he will do the, Vlasis will do the Batman procedure in that case. Maybe I prevent him, let's do lampoon. But I saw that real heart team was working in Interbalkan Center, and I really congratulate them. And Ilias is the eye of the Vlasis, and they are doing really very good techniques in their centers, and congratulations them for this case. And this case is really very hard case because very thick anterior mitral leaflet.
And also the problem with the septum, especially in this aged population, is the angulation of the very basal part of the septum, which provides an impression or a real thickening, but it's very regional and angle-shaped. So in this scenario, the alcohol ablation is not applicable.
I agree. It's not the thickness, it's the angulation, the S shape.
Yeah.
That can cause dynamic LVOT obstruction as well, so it's not a fixed.
Yeah.
Totally agree.
Okay, so it was a good